Hello and welcome to AvaSure's webinar, Keeping Veterans Safe Through TeleSitting. I'm Lizbeth Retruba, Chief Clinical Innovation Officer at AvaSure, and it's my privilege just to announce our moderator and panelists. Before I do that, just wanted you all to know that you're free to type questions in the chat box, and we've saved time for questions at the end. Last Thursday, we had a little prep meeting, and so I got to meet David, Shawnee, and Tiffany, and it was just a pleasure. It made my day, it made my week to meet these other nurse leaders who are really impacting the safety of our veterans. And Dr. Quigley and I, we get to meet and talk very frequently. So Dr. Quigley is a nurse scientist, nurse researcher, dedicated her whole career to the VA and preventing falls. She's a consultant. She's worked with the Joint Commission. Her body of work is pretty amazing. But I've introduced you before, Pat, and I know what you're going to say. You're going to say, I'm a nurse who wouldn't give up on falls. And really, that's the most important thing that you share in your bio. So I will let you introduce our amazing panelists, and I am looking forward to this webinar. Thank you.
Oh my goodness, thank you so much, Lizbeth Retruba, and our Vice President of Clinical Innovations with AvaSure. And Lizbeth doesn't introduce herself enough, but her background too is a clinical nurse specialist, and even though she introduces me as a nurse scientist, Lizbeth had the first published prospective study to be able to showcase the effectiveness of AvaSure technology. But as I launch this webinar with you with our dear and precious VA nurse leaders here, David Renfro, Tiffany Velleman, and Shawnee Fox, I want to say to you that these are extraordinary nurse leaders in the Department of Veterans Affairs, and they'll each tell a little bit about themselves, but collectively they have over 60 years of experience in the Department of Veterans Affairs, leading and shaping patient safety, veteran safety, and outcomes. So please, colleagues, please introduce yourselves. Who would like to start? David.
Hey, good morning, everybody. Coming to you from sunny California, out here by San Francisco Bay Area, specifically Palo Alto, California. I am the Deputy Nurse Executive at VA Palo Alto, but started there just after I got out of the military. USS Navy, went to the VA, and I have grown there as an LVN and RN, nurse manager, assistant chief, etc. Just worked my way up. So very, very thankful to be here and to share the successes not only of VA Palo Alto, but the rest of VA.
Thank you so much, David. And David, thank you for your service to this great country as a veteran. Thank you. And how about Tiffany?
So I'm Tiffany Billman, nurse manager here at the VA North Texas in Dallas. Been in my role as a nurse manager in the patient support flow area for about 1.5 years, but started my career in the VA 12 years ago as a Valor student in the spinal cord injury program, and that's where I spent most of my time until I recently transitioned here. So look forward to sharing with all of you.
Thank you so much, Tiffany. And Shawnee, we're so delighted for you to introduce yourself to everyone.
I'm currently the nurse manager of the float pool here at the Lewis Stokes Cleveland VA. I have been the float pool nurse manager for about 3 years. Prior to that, I was a nursing supervisor, and my entrance into the VA 18 years ago was as an emergency department nurse. So it's been a great career here at the VA. Looking forward to those last few years.
Oh my goodness, and Shawnee, thank you so much. And colleagues, as you get to hear even just briefly their introductions, again, we all want to celebrate Nurses Month with you, and I celebrate Colleagues Nurses Month with each of you as faculty for this webinar. We're just delighted to have you share with all of our audience. We have a rich audience across the country and other countries within the VA and from outside of the VA. So we look forward to you sharing about your leadership in launching the TeleSitter program and keeping veterans safe. So let's go ahead and get started. Let's start with our very first question for you to share and shape the knowledge and the expertise and skill of those who are using the TeleSitter program and those who are learning about it for the first time. Tell us a little bit about your role in your TeleSitter program and how long you've been working in this position. And anyone's welcome to start.
I'll go ahead and start. So my role, I saw this innovation when I was at a conference, and really immediately saw the value in keeping our veterans safe and our staff safe. But more importantly, I was really focused on the veterans who need CO and how that can be disruptive to have someone in your room at all times staring at you to make sure you're safe. So I brought that back to our facility and demonstrated that to the nurse executive and the director, and was able to help launch the program at our VA. That's my role now, is just oversight and helping grow the program.
Thank you, David.
So here in Dallas, I actually started about a year into the program. There was a previous nurse manager that had launched it. And so initially when I took over, something that was big for us was just utilization, because it was so new to the organization. So I was tasked to assist with spreading it and increasing our utilization. But again, it's been great so far in our facility, and we are looking to grow our program and acquire more cameras here.
Great, Tiffany.
When I was introduced to the AvaSure program, it was from one of our former nurse executives who is now retired, and she was one of the nurse executives for our CLC. And it sounded like a great program, and she just encouraged it so much. I had the opportunity to attend one of the seminars out in Michigan, and it was phenomenal. It was very uplifting to see the great work that AvaSure was doing. We actually just celebrated our 1-year AvaSure anniversary with our initial go live, and that was April 30th of 2020. So we're 1 year in, so yay for us.
Yay. So that's terrific. So David and Shawnee, you both launched brand new programs, and Tiffany, you moved into a program that was already established. So that's very exciting for each and every one of you. So as managers of your TeleSitter program, what are some common challenges that you've faced, and how have you been able to overcome those challenges?
You know, our first challenge was with every other piece of technology. If there's a nurse in the audience, you know, trusting the technology becomes a problem. So everyone liked the technology, but then to fully let go and trust the technology and the text behind the curtain, so to speak, was difficult for us initially. So our lead rounded with the nurse managers every shift, and instead of having to qualify who could be on the AvaSys, they had to provide reasons why they shouldn't be on AvaSys if they were on CO. And so we kind of did it backwards. And as we filled up, started to drive the top 3 list, every manager would have the top 3 of when there's an opening, who would they want, to enable us to keep the body of cameras fully working at all times. So I think that was our biggest challenge, but we're well past that now, just with those few interventions.
Thank you.
For here in Cleveland, technology has been an issue for us, but it's easy to overcome, because when we decided to implement this project, we brought all of the members of the team to the table, because we recognized early on that it would take a village to bring this project to fruition. Our initial implementation meetings included our OIT, our engineering, nursing leadership, nursing education, biomed, bed control, all of the different entities, so that we could bring this project forward and for it to be successful. And including everyone in this program, it has been successful. And as we continue to grow and changes occur within the organization, it just makes adaptability, it improves adaptability, because we already have the buy-in, we already have the support from other members of the organization. So that really made a difference when it came to our implementation.
Absolutely. And how about you, Tiffany?
So I kind of want to echo off of what David said with trusting the technology. I think that's always a barrier to get your culture and the buy-in. And so with that said, you know, we've had our staff, and I actually have a LVN TeleSitter lead as well that works with our team closely. And now it's the opposite, where we have nurses asking for cameras. So we've been able to really turn that culture shift, and we have nurses contacting us constantly, and we're, you know, using our cameras to the full capacity, which is really great. So now it's like the opposite, where, you know, people are kind of fighting for cameras now and trying to get them. So it's been a nice change to see.
One thing
I want to add quickly is that for those who have not started AvaSure yet, it does seem like an amazing hurdle to get over, OINT and get the team together and get everyone on board, driving this level of an initiative. There's a few things to remember in this process. One, clearly there are other VAs who have already done it. So reach out and network and bring people along with you as you do challenge your team to implement this. And two, don't focus on the technology, focus on the safety factor of this. This does improve safety for our veterans and our staff, and focus on the outcomes of what you're driving and not the technology that you're trying to share. People kind of hear about new technologies and can sometimes get overwhelmed with the process of getting that developed in VA. Focus on the main point, safety, and also focus on networking and pulling those experts around the country who are already doing this to help you get through it at your facility.
So here at Cleveland, one of the things we do is we employ very much a boots on the ground approach with frequent rounding on the units and interacting daily with our staff at all levels and with leadership. We work directly with our off-tour nursing supervisors. We provide education and support. But one thing that I think is very unique for us, we also work with our bed control center. They're even aware of where our cameras are located within the facility. So that helps in bed placement when it's time to make a decision. It's those small nuances that are very important in creating a successful program.
So if I may, Shawnee, if I could ask you, why is bed placement an issue when deciding this? Is that an issue? So maybe not all of our audience knows that there's mobile cameras and there's also in-ceiling units, the permanent solutions where the cameras are up in the ceiling. So is that a factor because your organization at Cleveland is using the ceiling units?
Yes, it is. Because we have the ceiling units in place, it's best for all the important parties to be aware of where those cameras are located. It's very important so that we have the correct bed placement from the beginning. When our patients admitted, we may need sitters. The knowledge of the need for the sitter may be at admission, so we need to do proper placement then. It just saves later for the patient, and it just creates a better outcome. All that patient moving is stopped. We just need to put that patient where they need to go, the best place. And that starts from our bed control center and working with our nursing supervisors on the off tour, as well as working with our nurse leaders during the daytime.
Yes, and that I think is important for all of our audience to learn from, because that's what sets Shawnee's programs separate and distinct, and that she has all the camera units. And Tiffany and David, you might share a little bit about how you use those mobile units, because I know everyone on this call is not familiar with the actual program.
Sure. So we here in Dallas currently have 24 mobile units. So it goes across acute care, critical care, and our long-term care CLC. So kind of going off what Shawnee said, we also work with our bed management system. The AvaSure, where we have ports active, are indicated in our BMS program, which is, again, our bed management system, so that bed control and staff always know like which beds are actually open that can accept an AvaSure camera. So our mobile units are on wheels, and our monitor techs move them as needed to admit and discharge patients. And with that said, we've bought an additional 24 cameras to grow our program and to be able to just increase our utilization overall.
Mm-hmm.
So for us at VA Palo Alto, first of all, we're extremely jealous of Shawnee and Tiffany because they have way more cameras than we have at the moment. But because of OINT and technology, we end up going with the fixed cameras initially in the ceiling, which we love. They're great, but it did cause us problems with having to move patients to get into a room with a camera. So I think we were live maybe 2 weeks, and the director came down and said, expand. So we did put in a purchase for the mobile carts, and also got permission nationally before you couldn't have a live, plug to plug in the AvaSure monitor, and that changed so that now we are able to move the cameras around more easily. So we've just done that expansion, and so we know it's going to go well, but we haven't had the opportunity to find out glitches in that process yet. But I can guarantee you that if we do find glitches, we'll be able to resolve them.
Yes, and so thank you for sharing about the program options. And so for all of our participants on the webinar, you can always go to the AvaSure website to learn more about the technology. But it does sound so exciting for all 3 of your VA medical centers because you're all planning to spread and have been spreading. So as you got started with your program, what kind of resistance did you have that maybe you could share with those people who are new and still considering this technology program? Because indeed, we have learned over time that nurses truly do trust this technology. That's been one of the hallmarks of its success. But I bet that you have had some resistance, or maybe even some of your new monitor techs that come on board. How do you deal with that? Or any disciplines, other disciplines?
So
for
here,
Cleveland, oh, go
go
ahead.
ahead, Connie. No, go ahead.
Go ahead.
Okay, so here in Dallas, and I would say probably across the country with our response to COVID, we've had to onboard a lot of new nurses. So it's been a challenge to get just, what is AvaSure, because everyone's obviously just really overwhelmed with how, COVID hit and the different units. And so we found that we were running into just a lot of new staff in general that didn't know a lot about AvaSure. So we actually made binder references for every unit and we individualized it to them, listed which rooms were active for AvaSure, inserted our telesitter policy in there. So we really tried to make it easy for them, like how to enter the order, how to DC the order in CPRS, which is our computer system that we have here, our charting system. So just kind of speaking on recent terms with COVID, that's how we kind of overcame that challenge, with just accepting of it, and then of course using it as a primary communication tool as well for patients and staff.
Mm-hmm.
Okay. For our program implementation, transparency and trust were very important. Staff at all levels we felt that they needed to be supported and have the appropriate education. We had a tremendous amount of leadership support. Inette was phenomenal, which is our my AD-PCS. She was phenomenal in leading this for us. She showed a phenomenal amount of support. It was very clear, very visible that she supported the program. And with our program, more importantly, it became a part of our daily conversation, every aspect, in staffing huddles and fall huddles, in meetings, in nurse manager meetings. It's talked about all day, every day. We meet throughout the day to discuss AvaSure with moving patients and things of that sort. Our staff, our nursing staff, are introduced to AvaSure in nursing orientation. So all nursing staff get a little bit of an introduction, and they get the TMS, that initial TMS module to complete, so that they're all aware. We also go at the springtime to see the physicians. The physicians need to be just as aware of this technology. So it's not just a nursing initiative. This is a whole hospital-driven initiative, and that's our goal. We want everyone in the organization to be aware of what's going on and the great things that we're doing for our vets.
Mm-hmm.
I mentioned earlier a little bit about what we did, but I don't want to underscore the passion our nurses have for being totally accountable for their patient, and to then just hand that over to a technician and not have that one-to-one there. I think it was a little bit of a transition. Not that they didn't trust the technology, but that they needed to get comfortable and used to that technology. And we needed, as we shared in the very beginning, we needed some small wins, which we got very, very quickly with AvaSys. And I shared with the team before we even got rolling that there will be bumps in the road. Let's expect those. And there will be a transition period of time. And we're going to have to market ourselves. We did a lot of training, both of the nurses and the doctors and the techs. We were comfortable going forward. It was just the transition of the staff. They need to see some small wins and see how safe it was. And that happened for us relatively quickly.
Well, you all 3 have shared your success in really helping this program to become part of the heartbeat of your culture, and to help everybody appreciate that when you have proven technology that's nurse-led, that it does indeed affect everyone's outcomes, improves outcomes, patients as well as the workforce, and interdisciplinary management. Now, I understand, David, that you were the first to admit a COVID patient into the Department of Veterans Affairs. So I'm sure all of you have experience with even moving the program forward to deal with the COVID population. How did you handle that?
Well, first of all, I would say that just getting COVID was a big fear for everyone, obviously, but it's actually what drove a rapid expansion for us is that we saw across the country where nurses were having IV tubes outside the room so they can manipulate pumps outside the room, but they still couldn't see the patient clearly. And so we wanted that rapid expansion because we could keep our eyes on COVID patients. We created a COVID unit that was it was an old oncology unit, so there were 10 isolation rooms, and our thought was we could have one of these monitors in the room and be able to see the patient directly. And I just want to key into like how clearly this could happen. We did have a non-COVID patient, but a seizure patient who would only seize rapidly and then be over, but the doctors never got to witness that. It wasn't really witnessed, and it was primarily at start in the patient's leg, and our techs were able to visualize that, see that, and alert them to that. So not only was the technology, it wasn't just a global thing that we wanted to see, but you could really hone in on the IV, you could hone in on whatever you wanted to with AvaSure. So moving in that direction during COVID just gave us a jump start for the safety of our patients.
Tiffany and Shawnee, did you want to share as well?
Sure. So here in Dallas, we were able to acquire a third monitor and the license that AvaSure had provided at the time when COVID was coming. And in that case, we actually used it to help providers communicate with patients. And again, we spread our cameras out, tried to keep them and prioritize them to be on the COVID units with our mobile units. And it was a good thing that a lot of our ports were open in those areas. So we were able to just move cameras as needed so providers could communicate. So it was a real big help in our facility.
Here in Cleveland, our biggest benefit from having the AvaSure cameras was the ability to deploy more staff to the floors, because we were able to utilize our AvaSure cameras to keep all of our veterans safe. And at that point, the ability to deploy those staff was priceless.
Absolutely. And we, Lisbeth, Jill Kaminsky and I just published an article about the deployment of and the re-engineering of AvaSure's technology during the COVID surge months of March and April last year. So we know that, beyond nursing, we had physicians who were using it, as you have shared, respiratory therapists that were using that technology to be able to, interact with the patients and keep patients safe and be able to manage them. So indeed, the technology is really helping across all interdisciplinary team members now, but it is the success of you leading the program. So tell us about how you bring staff on board, your monitor technicians. How do you hire them and help get them engaged and keep them involved, and how they work with the nursing staff at the unit level? Tell us about the monitor technicians.
So I always say that the monitor technicians are truly the heart of the program. I mean, the technology is one thing and it's a great thing to have, but it's our monitor techs that truly drive things forward. So when it comes to hiring, which I actually just did because we're acquiring more cameras, so we're trying to prepare and do the FTE before we get everything on board. And so with that said, I do try and have at least one person in on the interview panel, so at least they can meet some of the folks that we're trying to bring on board. I actually just hired somebody from that worked the private sector with AvaSure. So it was great to have that in her background and to be able to bring her on board. And she brought some things that she knew from when she had worked in a private sector hospital and bring it over here to VA. We also look for if they've ever had any experience with telemetry monitoring, things of that nature. Just staff that are used to, because it can be difficult, focusing on a screen all day is not typical of what nursing assistants typically do, especially those have been in the direct line patient care. So so we do look for those types of things, of people that can hold their attention and be able to focus on patients for that extended time on a screen.
Mm-hmm.
For our onboarding process in nursing orientation, those staff assigned to units where AvaSure cameras have been deployed are made aware of through their assigned educator that they'll be working on an AvaSure enabled unit. Nurses are assigned the AvaSure overview model in TMS, the talent management system, to provide awareness. All the STNAs are assigned to units where AvaSure is deployed or assigned the introduction manual and the training module in TMS. For those in acute areas that are assigned, their assigned nurse educator will provide a hands-on interactive training, and the employees will be assigned to orient with our regular staff that orient regularly. For the community living center staff, it's just a titch different because we have an entire long-term education, and it's included, AvaSure education is included in that as well.
You know, at VA Palo Alto, we are, I want to say, these are some challenging panelists with me here, but I want to say we have one of the best systems as far as that goes. We hired a gentleman by the name of Takeo Lee, and he was over, so great that you mentioned this, Tiffany, about telemetry. He was our telemetry tech supervisor. And, you know, he was just born a strong leader. And so we asked him, like, would you be willing to stretch and cover these technicians in this role? And he's found that really hiring within our staff that are doing the COs has been a real win for him because these are so veteran connected employees. You'd think, oh, they're behind a monitor, they don't need, you know, this super good personal skills. They do, because we will have a real personal touch to how we work with AvaSys in our areas. And the chief nurse, Eileen Nguyen, who's over the area, works very closely with Takeo through their tier checking, and they do panel interviews. They have input from the field, and we're extremely proud of our technicians that are working in AvaSys, and even more extremely proud of the leadership there too.
Well, you have shared such great stories about the monitor technicians. We have heard of dietary technicians wanting to become AvaSure monitors, but this for me was the first to hear about the telemetry people that you were able to help spread and become part of that. Very exciting. But you know, I know you also have really great success stories because it's all about the patient, and it's a patient experience and patient privacy. How do you help those monitor technicians be close to the patients? How do you help them really be able to work with the nursing staff at the unit level? How do you make that personal touch and individualized care planning really work and be alive at the unit level?
Well, you know, I shared with you earlier, the personal touch of AvaSys was critical for me in this process. And I absolutely love the fact that there was the two-way communication, but I wanted to be sure that the patient knew who was on the other side of the camera. So we do round the technicians round every 4 hours to talk to the patient and remind them who it is that's behind the camera. But that also gives them the time to touch base with the charge nurses and the nursing staff on the unit. This is just, you know, we've all had CCTVs and ICUs and stuff. That's kind of a disconnected way of looking at your patients. This is a very connected, personal way of working with your patients and having communication with them and reminding them to be safe, or reminding them that you're there so that the staff are safe as well. So it's been a real plus for us to have that engagement with the front line and the patients, and it allows the staff to connect as well.
Do other of you have, Tiffany and Stephanie, Shawnee, do you have examples too of how you engage the patient?
Yeah, so here we have two roles, techs that watch the monitor, and then also those that go around the facility and like admit and discharge patients from AvaSure. So all the staff are cross-trained to do both roles. So when they're rounding, our patients that are on camera are actively seeing, you know, the monitor techs, because they rotate daily, so it's a different person, and so they're constantly meeting the face behind the camera, the person behind the camera, however you'd like to reference to it. So that's how we make that human connection, so the patients feel safe and that they know that there are really people that care about them that are watching them on the other end.
Mm-hmm.
Here at the Lewis Stokes Cleveland VA, we do the same thing. My staff rotate. I don't have a group that just monitors patients. My staff rotate, so they have days on the camera and they also have time working on the floor. So that's that personal touch where they can speak to the patient and be like, hey, I remember you because we were talking on the camera the other day. And it's just nice to create that relationship, to know that there's someone, there's that familiarity. So it's great. It really is great.
And how did you get people to appreciate the importance of that stat alarm feature? For many of our audience, they might not know about that stat alarm feature. You know, we've been able to publish, it's unheard of, and it's such a success story of the nursing of this program, but you know, nurses respond within seconds to a stat alarm, 14.5 seconds. I mean, no one's ever done that. So how did you help operationalize and help get staff to be able to respond to it? And I know, Shawnee, you even changed how you use the stat alarm feature in the CLC. And for our colleagues on the call, CLC is long-term care, and the VA, that's the community living center. So share a little bit about how you operationalize the stat alarm.
So our stat alarm in our community living center is actually only used when there's imminent danger. What we've employed is a Vocera system. So I hope everyone's familiar with the Vocera. And we do an all call onto the floors. And that has had the greatest impact and the greatest response because we have a plethora of people who are responding directly to that Vocera call. It's just not as intrusive as the stat alarm, because in the community living center, it's their home. And with it being their home, the stat alarm could be a little intrusive and upsetting to the patient. So we employ the use of the Vocera, and we've had phenomenal results. We have many a save with that Vocera usage.
Mm-hmm.
So we're able to share the stat alarm data with our facility and specific units, so that way they can track their own metrics. We also have just recently deployed Vocera, and we'll be using that feature to help staff just respond quicker. I think with COVID, it's been difficult for some areas to respond just because of the gowning of the PPE. So we do understand, and we don't want people to think that just the data is what it is, because we know there are a lot of factors that tie into responding to stat alarms, but the staff on the unit are aware that it is imminent danger and that they need to respond timely.
You know, I want to say, first of all, 14.5 seconds.
It's amazing.
That
amazing?
Yeah, I don't know I can get anywhere in 14.5 seconds, but I do know our nursing staff can. And one thing I want to say is that our assistant chief, Heidi Garcia, worked closely with Michelle Selly. This was a case manager who wanted to help out with the education of AvaSure. And so all those elements of stat alarm, responses, all those kinds of things went through. Again, it goes back to kind of all that planning and having that strong leadership in place. The unit itself is, as you know, with that most emphasis, it's not right there where the patient is, but ours is on one of our units, 2C at the very front of the unit, accessible. So we can't thank our frontline staff in all of our med-surg areas enough for their responses like this. It's incredible, and we're just very thankful for the mentoring and coaching that AvaSure provided us, along with those who stepped up to teach, like the case manager, just stepping out from her role to help us. It's been great.
That's just such great sharing, and especially the monitor technicians and how they've been able to use that stat alarm, but the staff being able to respond to it. And Shawnee, that is such a great example that you shared in the re-engineering of how you use that stat alarm with a population which is different. We all have to control for context and appreciate that long-term care settings are different than an ICU or a med-surg unit. So that's a really great re-engineering, if you will, of how you were able to take that technology and make it work. But how have you helped to deal with the privacy issues? With maybe family members had concerns about privacy, how did you deal with that?
With our education, we have done a lot of education with not only the staff, but with our family members. When we place our patients that are in our long-term care areas, they receive a letter, which is very important to provide them with education. And in dealing with our privacy and allowing people to know that the camera's in use. I don't know if anybody can see my little camera.
I can, yes, absolutely.
So that's our little camera. It's just a small magnet that we placed on the door frame in our CLC areas to alert people that those cameras are in use. They're actively in use. So there's just another reminder to either the patient or their family member as we get ready to return to visitation at we'll call it the closing ends of COVID, I hope. I hope. We're seeing the downturn of COVID.
Yeah.
We've added it to our patient brochure at admission, so that it's not, it's something, it's just what we do, how we do it. And much like Shawnee, we have flags that stick off the door. I believe we got them from AvaSure, to alert people that there is, videoing in the room. The most important thing, though, to remind everybody is that it's not being recorded. That was really important to VA, obviously, but also important to our families and patients and staff. It's eyes on for safety, but no recording for later use.
In our acute care areas, the same cameras that I have on the doors are also on our whiteboard, our patient whiteboards, which identify those patients who have the AvaSure in place. It's just a small reminder for the staff without it being visible to members of the community.
That's a really good idea. I like it, Shani. I'm stealing it.
There you go. This is what this is about.
Called VA sharing.
Yeah, that's
VA
excellent. You
sharing.
might just put that little camera up again, would you? That's so cool with your camera. A little bit over. Yeah, there you go. So everybody could learn from this. And that's such great sharing, and that's what we love, is being able to help each other learn how we're using the program and making the program work even more successfully. And Tiffany, you started to share about using data. There is not everyone may know that there's a database. There's online reporting of nursing analytics. Can you share with the audience how you're using that database for showcasing how we're saving FTEs, helping to put the staff back, the sitters back to the unit level? Could you share with how you're using that data, and anyone else as well?
Sure. So the ORNA database is a very powerful tool that we use, and it generates like monthly reports, but you can also check in on a dashboard and it will tell you your utilization and different metrics. But perhaps one of the data points that was most important to our nurse executive here, who was actually the one that launched the program here as well, was the potential savings of FTE. So we started our program and was inputting data back from August of 2019, and to date, from April 2021, fast forwarding to now, we are saving an average of 55 FTE per month. And now that's based on number of hours where we're monitoring patients, which is incredible. And we actually also just passed the 200,000 hours of monitoring benchmark.
Wow.
If it's a benchmark, we should create a benchmark if that's the case. But yeah, so the data is a very powerful tool, and truly we can demonstrate that we're actually saving FTE and putting more resources back to the floors and utilizing our resources more appropriately as well.
Mm-hmm. David or
Well, I don't
Shani?
know if I can follow behind that, Tiffany, with that number of hours monitored. So here in Cleveland, we're at about 54,000 hours monitored. And as far as our FTE saved, we're about 25, 26 FTE saved. So in dollar value, that's quite a significant amount of savings for the organization.
Absolutely.
I'm teleworking today, and I don't have that data right in front of me, but I can tell you this: I'm definitely behind Shani. Okay, we're following her. We're chasing after her quite rapidly. But I think the one thing when it comes to FTE, that's how we really brought the program on. It's some pretty simple math about how many COs it takes for 10 patients versus a camera and one person. And really, again, I'm proud of the hours, proud of the numbers, proud of this FTE save, but more proud about the safety that we're providing all those patients. The 2,000 hours is 2,000 eyes on hours of our patients. You can't beat that. There's no more important priority to talk about than the safety of each and every one of those hours.
That's so important too. And, I know we shared about FTEs, but I would like to just showcase that the first article that Elizabeth, Jill, and I published in Clinics of Geriatric Medicine in 2019 was a year's worth of data across 71 hospitals, 15,000 patients that were observed and only 59 falls. Oh my gosh. Let me just say that again. 15,000 patients that were watched and only 59 falls across the entire country, and no one fell twice. It was absolutely amazing. That's almost getting to zero. And you're doing that great work. So what would you like to help everybody know? What's one thing you'd like to share with everyone that you really learned since you started this program? And then I have one more question for you before we open it up to the audience. So With all that you've learned in rolling out the programs as administrators, what's one thing that you'd like to share with everyone?
One quick thing I'd like to share is I never accept no. I find a way to get something done. And so those of you who may struggle getting this on board, that's just don't accept no. Keep finding a way to make it happen. Reach out to your colleagues. But the other thing I want to say is that, you know, the tele video monitoring of our patients is really, really critical. And think of you, and Shani and Tiffany, you can raise your hand. Have you ever had an NA that was on CO and the patient still fell? And the reason is because with the monitoring, you're seeing them as they're preparing to get out of bed, and you're seeing more of the patient. So I think that, you know, I just want to, people are fallible for sure, regardless of what role you're in. There's human error, but the ability of AvaSys to do what we expect and want it to do is so much greater than having somebody in that patient care room.
Yeah. Thank you, David.
So here in Dallas, when I actually first started, I learned that our nurse executive had approved for us to have an LVN telesitter lead. And so as a nurse manager, of course, most of you know we have a lot of administrative duties and other things that kind of take us away from that clinical piece. And so having an LVN telesitter lead to work directly with the patients, work with our monitor staff, has been a great bridge in increasing our utilization. So one of the new initiatives that our LVN telesitter lead started here was screening the ED. So getting patients on camera right when they're hitting the floor and not waiting for a fall to happen and then doing things, you know, on the back end. So we've been able to proactively admit more patients and again, increase our utilization because we're doing that initial screen, because we all have patients that have come in through the ED that have fallen in the last 24 hours or just weakness. Those types of diagnoses will catch our attention. So we know when they're being admitted onto a floor, we can catch them and put them on the monitors quickly. And so just having that support has been a big help. And again, so that person acts as a liaison between myself, the house supervisors, the monitor techs, and the patients. And it's just great to have that extra person to assist and to just kind of watch over the program as well.
Excellent.
For us in here in Cleveland, the first thing I want to say is you have to be adaptable. Whenever you're going to implement these programs, you have to be adaptable because change is going to be constant. Maintaining open lines of communication across the organization at all levels is also essential. I mean, we include all of our partners, bed control, environmental management, and our daily staffing huddles just to promote some transparency. And each unit that has a ceiling camera has a whiteboard that has, again, my small cameras. And I know, David, you're stealing my camera. If you want, I'll send you one. That we put adjacent to the room number just to identify that it's an AvaSure enabled room. I mean, AvaSure is included in each unit shift and safety huddle. For us, it has been an immersion in AvaSure to make this all very successful. I mean, again, bed control, all of these different parts of our organization are included in making this a functioning system. We couldn't do it without the team.
It is. It's such a tribute to each and every one of you as leaders, administrators, and rolling out the program and helping this to be successful because you've been able to overcome barriers and increase facilitators to make it work and become really a heartbeat of your culture. So it's wonderful stories. And so thank you. And the last question I just want to ask of you is, tell us about a success story or two that you'd like to share with everyone so that they can learn. And, you know, again, we know that you're in the VA, but a success story, because there's so many. And I would just like to say before you start to share is, we know that there's still even occasional falls that will happen or other adverse events, but if it happens, it's witnessed and you know what happened. You can't prevent them all, but if it happens, it's witnessed, so you know what happened, and you can totally transform those adverse events or not have long life falls. But tell us a success story. We'd love to hear about those.
So I'll start, and this really centers around patient safety. So I happen to be in the monitor room, just checking on the team, and one of my monitor techs had picked up on a patient that was taking some pills. Well, mind you, the nurse wasn't the one administering it. So Come to find out, so, and just to speak to the camera, so he was able to really zoom in and you really see what the patient was doing. And with that said, we told the patient, please don't take those pills, because we know that a nurse had not administered it. So the monitor tech was able to call the nurse and give them the heads up, and they were able to take away the medications. And so in that case, because most of our cameras are used for fall risk, but it's just so much more than that. And truly, that's supposed to show how closely our monitor techs are getting to know the patients, are paying attention to them. And it was a huge kudos to my team member. I mean, he potentially saved that patient's life, because as we know, he could be taking medications that could interact with it, and come to find out the patient had brought home medications from home that he was taking. So without the monitor tech seeing that, we would have never known and would have potentially missed something that would have turned into a safety event. So that's my good catch story to share with you all.
Yeah, that's a great catch. That went beyond good. That went to great.
Tiffany, we had a very similar thing occur here in Cleveland. We had a patient that had a history of illicit drug use, and he was observed in a drug diversion activity in his patient room. So his visitor brought in illicit drugs to the room, and we were able to observe the transaction. And in observing the transaction, my monitor staff were able to get in contact with the supervisor, because of course this happened off tours. So we were able to get in contact with the nursing supervisor, who then got in contact with police services, and they were able to intervene. So that was a great outcome, because we were able to secure those illicit drugs and keep that patient safe.
Now, in that scenario, Shawnee, did you have your little camera icon on? Did they know they were being watched?
So in this instance, it was in the acute area, and instead of the little camera, we have those bigger flags, those green flags supplied by AvaSure. And I guess the patient and nor their visitor was concerned about that. That was not their biggest concern. So, oh well, we saved that patient's life though.
Yeah.
No illicit drug diversion, and I'm sure that the individual who was involved with that activity won't be returning to the VA.
Yeah, yeah.
Visitor.
Yeah, great. Yeah.
Well, for us, I did share with you the seizure story, but again, there's just so many stories. You guys touched on some clinical. So the two things that I will share with you, one is our staff safety, that we do get patients who are in delirium and dementia and can throw trays and be dangerous, and having those eyes on to get the staff support and even the staff feeling a little more safe, I think is priceless. But one thing that seems small but is critical is preventing patients from eating when they're NPO. Seems like such a small thing, but that means they don't get their diagnostic or their surgery the next day, and it causes another night's admission. So all those things that we do, the safety, the drugs, the NPO status, that's not only just dollar saved, admission saved. If you're saving an extra day in the hospital, that saves patients from the vulnerability of infection. And I mean, it just can go on and on how we can keep our patients safe. So there are numerous things that we clearly couldn't list today that are great wins for us and improvements of safety for patients. It's endless.
And David, as you brought up too about workforce safety, Elizabeth, Jill, and I have also published work on keeping nurses safe. We've been able to quantify and trend some data on work on aggression, patient aggression on the nursing staff. And as you share success stories, one of the stories, and Elizabeth is back with us, that Elizabeth often tells is how a monitor technician was able to really warn a staff member before that staff member came into the room when they were at risk for being harmed by a patient. So there's lots of great saves, or even patients at risk for suicide, and helping people to stay safe when we know they're at risk of harming themselves. But as we turn things back over to Elizabeth, I just want to thank David and Shawnee and Tiffany for your great leadership, all the work that you're doing to advance this program within your organizations, that of your staff, your monitor technicians, your nurse executives. You're fabulous. If I was a nurse at your program, I would love to work with you as you launch your program. It would just be an honor and a tribute. So with that, I'll turn things back over to Elizabeth. Thank you so much.
I've been monitoring the chat, and we've got a lot of really great questions. So a few different people asked about fall rates and if you monitor fall rates off camera versus patients who are on the device, or if you've seen an overall decrease in falls. So I'll throw that question out there.
Well, I can tell you this. I have not heard one report of a patient falling while on AvaSure. Not one. Has not. I look at our, what we call incident reports, JPSRs, every single day. And now I'm proud that we have the strongest staff in the country, but I can just tell you that I have not received one report of a fall on AvaSure.
So that would be a yes, you've decreased falls then if you're using it on high fall risk patients.
And that's over what period of time did you say, David?
How long have you been live?
It's been more than a year. I don't, since we started, I take COVID as this block of time. I don't even remember what year it was, right? I mean, it's all confusing, but we've had it for probably maybe 2 years now. I have not received one JPSR about a fall while a patient was on AvaSure.
Yeah.
Wonderful.
Well,
Shani,
I don't have,
data? Go ahead.
oh, sure. Like, while I don't have the specific data, I know our fall rates have decreased across the board throughout the facility. We have had, I believe in my time here, about 2 incidents with falls, but you know, it was really approached with that, you know, just culture, you know, asking the monitor tech what happened, because there are times that things just happen that fast. And because of the number of patients we're monitoring and for how long we've had the program up and running, it's something that's expected. And I don't want the staff to feel that it's anything punitive, but it is good because we can really say or tell the nurses what happened, because obviously it was just the monitor tech witnessing it. But it is a reality. And so, you know, mistakes happen, things happen, but it's important for us to just huddle, learn what happened, and then try to prevent it in the future.
That's a great
Fall rates have been positively impacted as well.
Thank you, Shani. But I like that you mentioned just culture, Tiffany. Pat mentioned that I published on this almost 10 years ago now in nursing economics. And we did have a few falls on device, and this was before AvaSure had nursing support, and I was a customer back then. And it was we were able to learn from those falls on camera. So we had a couple falls that happened when there was not good communication between the monitoring staff and the bedside nurse. Actually, 2 happened in 1 month back in 2012, where the nurse had left a walker right next to the bed, and the patient, you know, got up with the walker, and the monitor tech assumed that it was okay because the walker was there, just beckoning the patient to, you know, come ahead, get out of bed by yourself. So that's what you can learn from that, and that's what we try to share as our nursing team works with your nursing team on implementation. We had a few questions on dementia patients. So I know, Shani, you talked a little bit about the CLC and how you use the stat alarm differently, but you have a dedicated station for your CLC, and I'm assuming that you sometimes have dementia patients there. So can you speak to, and could anybody, start with you, Shani, speak to monitoring for dementia patients?
So for our monitoring of our dementia patients, it is separate. For our community living center, they're monitored on a separate monitor, separate from the acute side. So there's that group is there. Again, for our CLC nursing assistants, they have an entire CLC education. So they receive an extensive education about dementia and the needs of our geriatric population, which is important in managing and maintaining safety for that group of patients. So it's very much a specific education, because we like to maintain with the center, the CMS, the Centers for Medicaid and Medicaid Services, the rules are just a little bit different. This is their home. And that's one of the reasons that we use the Vocera in lieu of using the other alarm systems, because we like to maintain that safety, that feeling of homeness for them. And it decreases the level of intrusiveness when we don't use when we don't utilize that stat monitor, that stat alarm, as you would under normal circumstances. And it's more so the education as well. A lot of education goes into preparing our patients and our families and our staff in taking care of this long-term care population of individuals. So again, I think the biggest thing is our education and being proactive in providing our care.
And you know, Elizabeth, some of what we've heard before too from some of the monitor technician staff, because you know, every patient's and resident's care is individualized, that when they get report, the monitor technicians get report, they will be told by the nursing staff at the unit that maybe there's some increased confusion or maybe there's some delirium going on, and this is not a good day to verbally interact with that patient. Even if they do have cognitive impairment, if you see something going on, just go ahead and contact the nurses right away. So that way we're not always engaging them, but we can still get someone to them right away, rather than actually even being able to talk with them and hear something over the camera. So that's been a strategy I know that's been used before.
Great point. And also, I think a few of you mentioned the learning modules and that AvaSure provides, and one of them, and this is all inclusive, and one of them is a geriatric sensitivity module that does have some specific training around monitoring for dementia patients. Couple minutes.
People, if I could just say, still, even people with cognitive impairment, they will understand yes, no. So there's some things that you can still say to them if you see, and you can engage them just enough to have them looking around to give time for staff to get in there and still not have them fall, you know, just to keep them a little occupied. So sorry, Elizabeth.
Thanks. No, that's a great point, Pat. And I guess I'll just throw out one more question is, are any of you using this on behavioral health patients in the emergency department or in other settings?
So here in Cleveland, we're actually looking to move to adding these cameras to our psychiatric assessment and observation center because of the successes we've had in our acute and long-term care areas, where you're going to use those cameras as a second look, just as a second observation site for our patients, just to keep both the patients and our staff safe.
Mm-hmm.
So that's an opportunity for growth with us as well here in Cleveland. We're looking forward to implementing that soon.
Excellent.
So here in Dallas, we are planning to open up to our emergency department as soon as we get our 24 additional cameras on site. That will be the first place where we grow and potentially can look into mental health, but at this time we are not monitoring patients there.
Yeah, same with us. We're definitely planning on expanding into those areas. The second look, obviously you have to have a primary eyes on for any suicide or anything like that, but the secondary look is great. And now I've got two great colleagues here that I'll be following after to see how it goes and learn from their lessons.
And I know that we've known organizations, Elizabeth, that have actually written grants to get AvaSure technology into their emergency departments because of the amount of violence that are occurring between the patients and the nursing staff. You know, the gang VAs and other hospitals that are in gang communities that have actually brought the technology into the ER to try and to reduce the amount of violence that goes on, keep the workforce safe.
Absolutely. The staff safety shouldn't be an afterthought.
Mm-hmm.
Thank you all so much for participating today. And those of you that didn't get your questions answered, we'll follow up by email and make sure you get your questions answered. And thank you for your time, David, Tiffany, Shani, and Pat. It was just a pleasure.
Thank you.
Thank you.
Thank you.
Great job. Thank you.